Michele Hughes from Ageless and Timeless. Today, I have a very special guest. I know I always say that, but today, a guest that I've been wanting to meet on our podcast for a few months, introduced to me by another very good former podcast guest named Debbie Barber from Vitali. And so Dr. Suzanne Ferree is a functional medicine practitioner in Atlanta. However, she does do telemedicine consults, and her specialty is actually with peptides. So I'm going to let Suzanne dive into the peptide subject, but she does a lot of other things as well. And she has just written a book. I think it was just released on last week. And the book is called Counterclockwise. There it is.
Mm-hmm.
Suzanne, just before we get to you and talking about you, tell me why you gave the name of the book Counterclockwise.
It actually was a patient who named it for me. I was explaining, he's a peptide user, and I was explaining to him about the book and what we're trying to accomplish, and that we've written the book. And I said, I'm trying to come up with a really creative name, and I think I'm going to call it this. And I had some different ideas. And he said, what about Counterclockwise? And my publisher looked it up, and I don't think there were any other books by that name. So it was perfect. It's the concept of trying to turn back time without sort of embracing aging, but also not allowing it to drag you down.
Mm-hmm. I love that. That's perfect. Yeah, and no one else had it, which is pretty amazing too, right?
Right?
Able to find a name. So good for him. Good that you asked your patient for some suggestions, right? Or he knew about the book. So let's start with you first. So I know, I want our viewers to know that you have had quite a journey to where you are today. So why don't you start us from the beginning, where you were a allopathic medical doctor, practicing with 50 patients a day, and then feeling like you weren't making a difference and wanting to do more. And then, as always happens to so many of my guests, have said this, that they've had an event occur. Like in your case, it was an injury, because you're an athlete. And you were looking for some answers. And so this is, what I don't want to steal your thunder, but this is, sort of what led you off to a different path. So why don't you dive in and tell us more about you?
You have a great memory. You must be taking memory peptides.
Well,
so I've done family medicine. That's what my basic education was in family medicine. And then about 10 years ago, I had some patients that came to me and said, hey, I've got this bioidentical hormone. Will you mind filling the prescription? And I said, a what? And so I filled the prescription, and the pharmacist said, you clearly don't know what you're doing. Can I send you to a conference? So my local compounder sent me to a conference, and it was great. He was really sweet, and the conference was great. It was called Get Out of Line. And it really just told me that there were so many other things out there we can do to take care of patients, because I'd see over and over again these patients they were definitely sick, but they were not getting better with conventional medicine, and their conventional labs were not showing anything wrong. So if I was just to look at their labs, I would say, well, you probably have a Prozac deficiency, and would treat them that way. But I didn't know a lot. Medical school doesn't teach us a lot of what I now know. And I didn't realize how much the gap between bench research and clinical medicine, there's such a huge gap there. And there are big mountains for the pharmaceutical companies and for the industry in general to climb over in order to get to from the bench practice to laboratory practice into a clinical practice where you're actually treating people. I just did a podcast or an interview the other day with the Washington Post, and the man was asking me about a drug that I prescribe for anti-aging purposes. And he said, well, there's no human studies in this drug on using it for anti-aging. How can you justify using it in humans? And I said, well, there are lots of human studies. It's just not for anti-aging purposes. We have lots of drugs we do that with. So I think that what I'm trying to be is one of the doctors that helps to bridge that gap. And because I have a lot more time, I only see about 5 or 6 patients a day. I actually can go and do a lot of research. So if you were a new patient coming to me, I would be able to go and do some research, find some things that maybe were outside the box that hadn't been tried, that had been researched but hadn't been tried on people yet, or had been used for another reason. So it's a real blessing to be able to help. There was another layer of patients that got better, and another layer of patients that got better. Every time I would do some more research, we were able to find something else that helped people get better and better.
So where did you actually go to medical school, and what was your degree in
Mm-hmm. So
it
I went to Emory, and it was in family medicine.
was family medicine. That's what you
Mm-hmm.
said. Okay, so then did you go back to, I know you, I remember you saying you went to A4, the American Academy of Anti-Aging, and did some advanced studies. What were those studies in, and how did they help you?
Sure. They have an amazing fellowship program that's very thorough. It looks at all the hormones, gastrointestinal health, metabolic health, nutritional health. It's a cardiovascular disease. It's a very thorough program. And it's sort of like a fire hose to the face, especially if you've never delved into this kind of medicine before. It really is so much information. So you spend really 24 hours over a 4-day period just tackling a topic in heavy rotation. And so you're there for 10 hours a day for 4 days straight, and you come home with all this information. So I did their basic fellowship program. And then, of course, I was still hungry for more. And I went back and did their advanced endocrinology. And then I did their peptide course. I'm in the middle of their stem cell course, their fellowship program for stem cells. There is something to be said for having the education to back up your experience and to back up your use. So even though we already are doing a lot of that in our practice, it's nice to have the official document on your wall saying I did actually complete the recommended coursework in this particular program.
Suzanne, how do you know which group, like A4M is very, very renowned, but did you know which group to choose in order to get that advanced education? And how do you know that what they're teaching is the efficacious, what you call it, the efficacious result that you want?
For me, it was exactly the right thing at the time because I was very allopathic at the time. And one of the things I liked about A4M was that they are very evidence-based. So all of their teachers are required to use up-to-date research to back up what they're saying. So as opposed to, I just got back from a conference this past weekend in Miami on stem cells, and most of the lecturers did not use, there were several that did, but most of them did not use references to back up what they were saying. Not that there aren't plenty of references for stem cell research or for regenerative therapy, but they did not really use a lot of that to back up what they were saying. And so I like being able to go to a patient and say, look, I have 20 articles to support why I think this would be a good choice for you. Because a lot of the things we do, there's not an FDA approval. There's not a 16 articles that say this is exactly, in this particular disease state. I just know because I practice cellular medicine, I know what it does in the cell, or I have a pretty good idea of what it does in the cell. And I know what the disease state, what the problems are in the cell, what the cell is experiencing as a result of the disease state, or what problem is causing the disease state. So I can match those two up in treating. And that's how we use the combination of things that we use, is because I know the disease state, I know the mechanism of action of the drug or the herb or the protein or whatever it is that we're using.
I'm kind of curious to know when was it that cellular medicine became the cornerstone of good health, that people recognized in your positions that the cell is where it all begins and ends in terms of overall health?
Well, as I mentioned before, I really think that the bench researchers, the ones who practice at universities in the research lab, not seeing patients, but who are using lab rats, I think they have been looking at that for a long time. And I think that we've gotten away from that with the pharmaceutical industry to some degree. And then as we get around that became with the insurance companies and the pharmaceutical industry, we really became a very diseased disease-focused
Right.
healthcare system. And I think even as functional medicine practitioners were coming out, they were still very disease-focused in
Yep.
their, they may have used alternative therapies to treat, but it was still very disease focused, as opposed to let's just get the cell to do what it needs to do, and then
Right.
the disease state's going to go away. So
Right.
your body has this beautiful innate ability to heal itself if we
Yeah.
give it what it needs. Just put a little tweak here and a little tweak there, and now the cell's actually able to do what it needs to do. And it has all of the capability to heal itself if we can turn back on some of those genes, and we can just start a cascade of action. We often will get the cell to heal itself.
Today's podcast is brought to you by International Anti-Aging Systems and Profound Health. The founder, Phil Mickens, has been a guest on Ageless and Timeless, and those who know him personally, as I am so fortunate to do, can attest to his knowledge, experience, authenticity, and his passion to help make the world a better place, with a commitment to work profoundly to improve our health. I personally have used the peptide bioregulators, some of his hormones, and his skincare products, and I can attest to their efficacy. If you want those unique and value-added evidence-based health products, then IAS and Profound Health are your number one resource. We're going to flash on the screen the different websites that you can use in order to order their products. And no matter which website you go to and which products you order, please use the Ageless code for a 15% discount. And also, you want to let patients know that chasing symptoms is, the typical way that, an allopathic medical doctor or a drug advocate, pharmaceutical drug advocate, would say is the way to go. But actually, you're chasing the symptom. You're not solving the problem. So, yeah, you might have, let's say, chronic depression. So you can give them, a drug like Prozac or whatever, but yet you're not getting at the root cause of what is causing the depression in the first place. So how do you get around that in your practice? I'm sure you have many, many moments when you have to defend yourself for how you go about doing what you do.
Yes. So, sometimes something as simple as that, I can say sometimes we will use things like Prozac as a temporary measure to get you through the next phase. But most of the time, I can get patients better fairly quickly with just decreasing their inflammation, with working on how their intestinal health is, with changing their diet, with improving that mucus layer on the lining of the intestine, with restoring their tight junctions, all of those things. If we can get those things working again, often I don't have to do a lot of intervention, and they work pretty quickly. Patients recover. Your body wants to be well. So it's a matter of fixing it. Most of the patients, thankfully, who come to me come kind of knowing what we do. They know we do hormones. They know we do peptides. They know we do, all the things that we do, ozone and EBU and all the things. And so they come with an expectation of that sort of, I'm not having a conversation with someone and saying, hey, we really need to consider doing bioidentical hormones on blah, 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 because most of them already know that's what we do.
Do you have a kind of a list of requirements that you put out to before you'll accept a patient? Are there any prerequisites?
I think the biggest thing is and this is just one of the things I teach my nurse practitioners and the residents that come through our program, is that the patient needs to be engaged as much or more than you are. And so if they are not willing to participate in what you're doing, they're not the right fit for us. And that's fine. And they may not be in a position right now where that's what they want to do. Maybe they don't want to change their diet. Maybe they don't want to begin a resistance training program. Maybe they don't want to participate. If that's the case, that's wonderful. But please give up your space to someone else who does want to participate. And we want patients to get better.
Right.
My practice administrator does most of our contacts with people first. So
Mm-hmm.
she'll engage with them and find out if they're a good fit for us. And then she'll route them through me. We do about a 10-minute visit or 15-minute visit to be sure that they're a good fit for us. And then that we're a good fit for them. And
Right.
that then we will schedule them for initial visits.
So, okay, so let's go back. I don't want to forget about your journey. So you did speak about the A4M and how that changed your educational side. What about the physical injury that you suffered, and how did that affect your journey?
So I used to be a competitive runner, and I got a condition called Trendelenburg, where you're using your hamstrings more than your glutes to do the action of running. It's just it's a common runner's injury, and then you end up with a high hamstring strain because of that technical form. I didn't have a trainer at the time, and I was doing that on my own, and I've learned that lesson now. And I did not have someone to help guide me through form. And you think running is just running, you don't have to worry about what you do, but when you're running the distances or when you're running competitively, you really need to have someone who's helping you with that and giving you training and stretching exercises before, and how do you cross train for other things. So
Mm-hmm.
this injury just persisted for a while, and I missed a couple of big races and finally said, I need to switch this up. So I changed what I was doing to a more resistance training program. And then looking for what could I find, I went to one of the conferences, and they had a they had a breakout session that was about mechanogrowth factor, which is an IGF derivative that the body makes in response to injury. And
So
this
explain IGF to our viewers.
Sure. IGF is what the liver makes in response to the release of growth hormone from the brain. And IGF is one of the repair hormones that's very involved in not only repair, but helping the cell to choose which substrate, the most efficient substrate to make energy. So let's say you go to the refrigerator because you're hungry. You could either pick a Twizzler, you could pick a chicken breast and some broccoli, or you could pick a what's a good fat, a hummus or some other good fat, like an avocado. And so
Okay.
the same thing is presented to the cell depending on what your diet looks like. And so the cell has the opportunity to choose which substrate it uses. And depending on which one it uses, as you know, if you had a bag of Twizzlers, an hour later, you're going to be hungry all over again. So, and that's the same thing with the cell. If it's using straight glucose, you're going to have a harder time. You can make energy quickly, but you'll be back to needing refueling again. We don't want your body to use protein as a substrate because that's burning muscle, and all of us need muscle for those beautiful myokines, the chemicals that are released from exercising muscle that help to maintain our youthful state.
Right.
And so the most efficient substrate for a cell to use is actually fat. So I love that concept about the cell. And that's one of the things that IGF-1 does, is helps the cell to be able to choose that. It's way more efficient in its use of fat to make energy. And that just allows the cell, and we're talking about every cell in the body, to allow the cell to do its job, the heart muscle, the liver, the kidneys, the skeletal muscle, etc. So
Yeah.
very efficient.
And also, IGF-1 is the way you measure human growth hormone in the blood, right? So
Exactly.
you don't have a direct HGH measurement, so that is kind of a backdoor way to measure, but it's as accurate as you can get to understand what your growth hormone levels are.
You got it. It's tough to figure out because in women, especially, we probably have 7 to 9 peaks of growth hormone release throughout the day. So your peaks are going up and down and going up and down all day long. So if I'm checking your
Right.
level, I don't know if we're on a rise or if we're at the peak or if we're on a decline. I have no idea where we are. And IGF-1 is
Right.
a little bit more stable. It's still not a perfect test of what things are happening with growth hormone, but it's helpful. So we do that. We do a combination of others that give us a better idea of what your growth hormone levels are.
So that actually brings up another thought I have, is when you do your blood work, your lab tests, what kind of tests do you do with people? And I know I'm segueing away, but it's very important, I think, for people to understand what is it that you are looking to find out, particularly with a new patient. So what are some of the most important measurements that you require in your lab work?
I think it's interesting. I have learned doing this kind of research so much more about the very basic complete metabolic panel and complete blood count that I've done for years and years. I just didn't know how much they were telling me. So when I go back and look at the bench research, the laboratory results, research on things like albumin, it's an amazing marker of aging. And the reference ranges are so different when you look at it from a lab point of view than you look at it from a clinical point of view. And so even when we do some human studies, are showing that the normal albumin level is over 4.5. So if I see a patient whose albumin level is declining, and I get labs on patients probably every 3 to 4 months, so I can trend how they're doing. I know if their albumin level is under 4.5, we have to look at several things. First, we have to look at their liver function. We have to look at what their protein intake is in their diet, how much resistance exercise they're doing in their life. And of course, their catabolic hormones like thyroid and cortisol. And by catabolic, I mean breakdown hormones. So I'm looking at their balance between their catabolic and anabolic or growth hormones like estrogen, progesterone, testosterone, and their catabolic cortisol, TSH, to see if they're in a more catabolic state, which I would presume if their albumin is low. We see that a lot in post-infectious syndromes and in patients who have sort of chronic disease states. We'll see they're low, and I can say, look, your albumin's gone from so-and-so to so-and-so with the treatment that we've just done. And that's just a simple blood test that you would almost always, every doctor is going to order a complete metabolic panel, and you'll see that albumin level. So there's several little points like that that I did not know as a regular allopathic doctor that I use now to help guide patients. So that's not all we do. Of course, we run a large panel of hormones, looking at the ones I just mentioned, plus prolactin, of course, the growth that we mentioned as well. And then we look at testosterone, estrogen, both of the estradiol and estriol. We look at a complete thyroid panel, which most allopathic doctors aren't looking at. And we're trying to, and then we look at a lot of inflammatory markers. So I'll look at a galectin-3, an 8-OHDG, a cystatin C. These are all just markers helping me know where the patient's overall health is, and IGF, transforming growth factor beta. We look at their IL-6, so other inflammatory markers, trying to see what's your basic inflammatory state, and do I need to be addressing that in general, or can I move forward and begin looking at the intestines? So the first place that I would go after that is intestines, and often we'll look at just a basic PCR test, which is looking for specific pieces of DNA, looking for bugs, but also I'll look for do a intestinal panel that will look for what kinds of inflammatory markers and like calprotectin that would be present potentially, and eosinophil X that would be causing some inflammation in the intestines, looking for things like ulcerative colitis, Crohn's disease.
Well, the liver is another, the alkaline phosphatase, and the other liver markers are what you're going to be really concerned about, particularly as you look at the microbiome and the GI tract. It's really what they say, 80% of our immune system. And I'm very pleased that when you said that the first thing you look at is the intestines, or at least the GI tract. So you understand, obviously you're practicing the medicine that preaches that. So what, and you didn't mention DHEA and cortisol, but of course those are very important, the sex hormones, right? And testosterone, I did say. But when you do testosterone, do you do the whole panel of testosterone, the free testosterone, and you do the whole things?
Yeah.
One thing I want to say, Suzanne, it is so complex for the layperson. And you are simplifying it. I mean, I congratulate you for doing that. You make something complex seem very simple. But there's so many names that you just said, even just in the blood work. I mean, yes, most people know albumin is protein, a measurement of protein. But these other tests that you mentioned, do you sit down and explain to patients like what is each test and what are we looking for, like you just did with us, but obviously in a very rapid way because we're on a podcast? But do you handhold with the patient to let them know what they're getting?
So we have the system we've worked out is I usually will see the patient and do a very thorough history and exam, and then we'll draw their blood ideally on that first day. And then I see them back 10 days later. Maybe we'll do some small interventions between them that might make some good impact just so they don't feel like they're being abandoned. And we do some sort of impact the first couple of days. And then I'll see them about 10 days to 2 weeks later, and we'll go through their labs. I usually will have commented on their labs and sent them to them on the portal before I see them. So they have a chance to sit down, read, digest, come up with some questions. It doesn't always happen that efficiently, but that's our goal. And so then they can sit down with me and we can go through line by line exactly what happens. It's difficult because I don't have the whole picture. Even 2 weeks later, I don't have the whole picture of what's happening. So let's say their CRP is high, but in between when I saw them and when they come and see me again, they had some sort of dental thing that happened, or they got an upper respiratory infection that popped up 2 days after they saw me. Well, probably the body was already ramping up that inflammation when they were in for the blood work. And so unless I have that information, so that's why we sit down and talk about it, because I can tell you what that result means big picture, but without knowing what it means for you, I can't tell you exactly what it means. And we have to look at all the labs collectively to make a decision about each one fits together like a lock and key. And I'm not just doing one test for one disease state, and none of them are perfect. So we're putting together these incomplete pieces, trying to come up with a whole, and then making a plan for what our next steps are for optimizing your overall health.
So the one thing that you said, CRP, I want people to know that that stands for C-reactive protein, and C-reactive protein is a measurement of inflammation, but it also has a direct measurement to your heart health, correct?
Yes.
So normally you would do your lipids and then your CRP and your homocysteine to get and also the particle size, to get a better picture of your health. So you do the the lipid test itself is pretty complex.
It is. It is. Yes.
I just give you kudos for trying to make this, understandable to people when they're just, they're trying to take responsibility for their health. And yet, it can be daunting.
Yes, it's a lot, especially if you are a high achiever and you have high hopes for yourself. It can be very frustrating when I say, my goal for your blood sugar is to have it less than 87, because a fasting blood sugar greater than 87, there was a study that came out in 2014 that for every point above 87 that your fasting blood sugar goes, your risk of developing diabetes goes up by 6%. So if you're at 100, which is what everyone in the allopathic community considers abnormal, you're already at 15 times 6. You're already at 60%, 70% increased risk of developing diabetes in the next 10 years. So there's no need for me to wait. Most of my patients don't want me to wait until they're already like, oh, by the way, surprise, you have diabetes. I want to say your blood sugar is starting to trend high. What are things that we can do to help reverse that? Because that's one of the things we know is a marker of overall aging and disease in general. And so I know that your cells are stressed if your blood sugar is a little on the high side. So how do I help your cells do a better job? And there's lots of things we can do to intervene on those things.
So I keep segueing back to your injury and to how this changed your life. But I also remember you said that you had something else happen because you're a weightlifter, right? And say that you had something else that was life-changing with weightlifting that caused you to, move towards functional medicine.
So the weightlifting actually started around the same time. I think the big thing that you're maybe referring to is that the gyms were all closed during the pandemic a few years ago. And so the only gym that was available around my area, the gym I went to was closed. So the only gym that was available was this powerlifting gym.
Oh,
And
that's what.
so I went to, they were open one person at a time in the dark. They would let you in the back door, and
Right,
you would be able to train with one person at a time. So that's
right.
been really fun. And this is like I said, a powerlifting gym, and I've been able to compete with them, with their team a few times. It's been really fun.
Okay. So have you had injuries doing the powerlifting?
I did back in August. I was training for the last competition,
Hmm.
and just before my competition, I think this was a case of I was trying to get into the lower weight class. I
Hmm.
was more competitive at the lower weight class, and just on the border of that weight class. So I wanted to kind of drop down if I could. I think I was overtraining, which I actually don't think is overtraining. I think it's undernutrition, and
Mm.
so I had probably been cutting my total caloric intake too much for the amount of training I was doing in competition prep. And I sustained an injury. I had been under some stress from some other things as well. So sustained an injury. That also has done better. We've treated that with some ozone, some neural therapy, some peptides. And so that's been really helpful.
And what exactly is neurotherapy?
Mm. It has been so dramatically life changing for our practice. It's been sort of the little missing link for us, and it is a centuries old procedure that's primarily done in Germany and in South America. And they use the old procaine. So originally, anesthesia was done with cocaine.
Yeah,
Procaine was the original derivative of cocaine that did not have the addictive potential of cocaine.
yeah.
And procaine has some unique properties that the other anesthetics don't have. Number one, its metabolite is PABA, which has some unique ways that it works in the cell
Yeah.
to reestablish the membrane potential of the cell. It's a fascinating molecule how it works. So cells that are under stress will have a change in their energetic ability to function. So their sodium potassium channels will drop, and the area will lose blood supply because of that change in polar charge. So
Mhm.
then we can go in with something like procaine, and we can reestablish that polar charge. So now the cell walls work better. We can get nutrients into the cell. We can get toxins out of the cell. We can get fuel sources into the cell that the cell needs to do its job. And now the cell begins to work better. Often it requires several treatments, 2 or 3, usually, for it to be effective, depending on the situation. And where we've seen a lot of benefit is in stress, PTSD, anxiety. We do what we call a therapeutic stellate infiltration. And it's been dramatically beneficial for several of our patients in reversing and supporting their recovery from all kinds of illnesses and injuries.
So, and then how do you combine that with the ozone?
So you can either use it at the same time, or you can use it, you can do separately because it's available IV. The ozone, they work in separate ways, but they do a really beautiful symbiosis for the cell. So the ozone is converted into the hydrogen peroxide or lipid peroxides, and that's one of the ways that it works in the cell is by improving the microbial milieu in the cell and in the space where the cell exists. So
Mhm.
now the cell's not having to fight off those microbes. It also triggers the NRF2. NRF2 is one of the proteins that helps. You've heard of antioxidants. Well, once we get very stressed, our cells become very stressed. We have not enough antioxidants to handle all of the reactive oxidants or the oxidative stress that our cells have. And
Right.
so NRF2 is the trigger that allows the cell to recycle those antioxidants like vitamin C, vitamin E, glutathione, so that they are available for use again. So that's a great ozone is a great combination. So now we have the procaine, which is helping with reestablishing the cellular membrane polarity. And then we have the ozone, which is not only removing any microbes, but also triggering the antioxidant benefit so that your mitochondria are able to function optimally with plenty of antioxidants. And it's this beautiful symbiosis. The cell is in this beautiful milieu and now can do its job better.
And you do this by IV?
Or sometimes into the joint, sometimes IM. It depends on the patient, depends on what the patient needs. A lot of neural therapy can be done just subcutaneously. It's taken up by the cutaneous nerves, and then that travels along the nerve to the main nerves of the spinal cord and the brain. In fact, most people will say that they have sort of a lightheaded, euphoric feeling, a joyful kind of feeling. Some people have an emotional release. I know you've probably heard of people holding emotion in their scars, and a lot of neural therapy is treating those scars with procaine, opening up those channels, releasing the scar so that there can be communication through the fascia in that area.
Wow, that is fascinating. You know, I'd never heard of that before. I knew of ozone therapy, but not of the neural therapy. And are you one of the few clinics that are using that, or is that pretty widespread?
I think it's not as common as it could be, but I think there are probably a handful of physicians around the country doing it.
Mm-hmm. Yeah, I'm just wondering if there's anyone out here in California. I'll have to ask you that when we get offline.
Mm-hmm.
So Suzanne, I don't want to lose the most important part of this podcast. I want you to talk about your book, and segue over to that if you don't mind, because you focus on peptides, and you're one of the few courageous ones that's taken on that subject in a very simple way to help the layperson understand. Because honestly, the number of peptides and you'll get into that, I'm sure, but just the number of peptides that are out there and the different modalities that they address is again another daunting subject. So I started reading your book. I had to ask Terry to send me a hard copy because it was hard to read it on the PDF, but because I want to take notes. It's just it has so much information. I just, want to be able to jot down notes on a page and then come back to you with questions. So if that's all right with you, if I could have that hard copy, I'd really appreciate it, because this is a really important book. I just want everyone that's watching today to know, counterclockwise, you need to go. Is it on Amazon already?
No, it'll be on in 2 more weeks, March 4th.
Okay, so just the beginning that I've gone through maybe 3 chapters, and I'm like fascinated, but I also, like I said, I know it's going to be a bit confusing to people. So let's talk about the peptides. Let's try to take a very simple look, like a 30,000 foot overview of peptides. Why don't you start from the beginning and just give us an overview?
It's pretty exciting. So think about this, that most of the proteins that we eat in our diet are over 150 amino acids long. So amino acids are the building blocks in our bodies. They create protein. And so if a chain of them was put together, sort of like a string of pearls, depending on which sequence they're put together and how long the chain is, it will do a different thing, and it will bind to a different receptor inside your cell. So peptides are not just drugs that we give people. These are actually things that your body makes. So there are hundreds of thousands that we don't even know about yet. This science is still evolving. It's very exciting. But since the 1920s, we've known about peptides like insulin, like secretin, which was the first one that was discovered.
Right.
And if you all remember Pavlov's dog, that laboratory researcher was actually doing research in finding peptides in dog intestine. Right. And so he was doing research and he found secretin was one of the first ones back then. So it's very exciting. And this science sort of drug along because there wasn't a really easy way to make them quickly in a lab until around 2005. So it was done in a very labor intensive process, or we had to take them from cows or pigs or other humans, like human insulin, for example. Now peptides are everywhere. The pharmaceutical companies are aware of them. And because we're able to make them en masse, we are actually there. The pharmaceutical companies are using them. So there's some relatively new migraine medicines that are that are being used that are peptides. There are there's some diabetes and weight loss drugs that are out. And that's where most of the research and development with peptides is going right now, is in the oncology space and in the metabolic health space. So
Right.
it's a very exciting time for us to be doing this kind of research. And there's every day new peptides being, especially because of artificial intelligence, there are brand new peptides we can learn about every day. Every time I look on on Google Scholar, there's a new one that I didn't know anything about. So it's an exciting time. And although it could be disappointing and discouraging that the FDA has given us a thwart in our process, the exciting part is that's not because of any reports of adverse effects or of patients not having good outcomes or efficacy. It's not because of that. So that's great news. And it just means we have to be more creative and keep doing research. So that's what we're doing.
Yeah. So let's talk about the top 10 so that people know what you use most frequently in your practice. So let's start one by one and talk about each one so that people understand what it does and what kind of results you've had in using them for years now.
Okay. So one of the reasons I wanted to write the book was because I felt like there was a dosing difference between men and women. And so I wanted to have a book that really addressed the difference in women, because these have been studied for years or used for years in male, primarily bodybuilders. And I knew that there was a difference in women, and I wanted to be able to give that information and to be able to provide that. So what do I commonly use? Almost always, everyone's different. So to say what do I use in every single patient, that's a tough one. But I would say almost always I'm going to use something like a growth hormone secretagogue, and there's lots of them that are out there. I don't usually use growth hormone directly because it can raise blood sugar and it can raise cortisol. And I don't know many of us that need a higher cortisol. So I like the growth hormone secretagogues because they don't raise blood sugar or cortisol typically. All of this, of course, is done under the supervision of a trained physician who knows how to treat this disease state. And this is for my patients, a general idea of what I do with my patients. And so I'm going to use a growth hormone secretagogue. And part of the reason for that is that patients, again, this is at the cellular level. I want the cells to be able to choose the proper substrate for them to use for energy and to be able to be very efficient at creating energy, at making mitochondria, those energy generators in every cell. And that happens when you use the growth hormone secretagogues.
Helps to build muscle, which is one of the most important issues for people, particularly when they're doing weight loss, like Ozempic or Mounjaro or Wegovy. You know, their potential is to, they'll lower their insulin level, they'll lose weight, but they also lose muscle. So the secretagogues, what you're talking about, help you to counteract that, correct?
You're right. That's excellent. So what they actually do is they improve your recovery after injury so that you're able to get back to sport more quickly. So the research doesn't really support so much. It's interesting to me that it's banned by WADA because there's not a lot of research supporting that it actually improves your strength, improves your speed, improves your muscle. But what it does do is allows you to get back to sport quickly. Because you're able to do that, then you're able to build muscle better. Whereas if you were not using them, you would take a longer rest between training sessions and it would be harder for you to gain strength or muscle or speed.
So was ipamorelin one of the ones that you liked in that category?
It's one of the ones we liked in that category. Yes.
And what else? What are the other ones?
And I do like that one in my female patients. They tend to not get so much hand swelling, which is one of the potential side effects. They tend to not get the hand swelling is the big one that women will report, and it also, ipamorelin tends to move the bowels a little bit, so they get that nice resolution of their constipation.
Yeah, that's very important. So, okay, so that's a good one to jot down, everybody. Ipamorelin. I've used it and I really like it a lot. And I ran out of it, so I'm glad we're talking about it, because it's reminding me to go get another prescription of that. Okay, what about?
It will be more difficult to get because the FDA has told the compounding pharmacies they are no longer allowed to compound it. I do think, however, that there is a pharmaceutical company that owns it and will be coming out probably in the next couple of years with some version of it, pharmaceutical.
I thought, though, you could get it from a research laboratory, even if you can't get it from a compound pharmacy. Like Limitless Life is a good research lab, right?
So I don't recommend that patients do that, because I don't know what they have not been tested. In fact, if you get a vial from one of those places, it will say for research purposes only, not for human consumption. They have not been tested for the toxin. So the way that peptides are made requires a resin at the, this is a simple way to explain it, but there's a resin at the bottom that's sort of sticky. And then they put the amino acids in one at a time to build that string of pearls. Then they have to chop off that resin. Well, if they don't completely chop off that resin off the bottom, then it can be liver toxic. Again, that's an oversimplification of the process, but if they're not tested for that, you may find that there's a problem with it. And that's what we're seeing. If there are reports of toxicity from peptides, it's usually coming from a research lab and not from a compounding pharmacy. So that's where we get concerned.
That's a really good point. I'm so glad we talked about that, because I don't think everyone understood that. And so ipamorelin's off the market for a while. So what would be the replacement that would be next best that is available?
So there'll be 3 that I know of available in the next couple of months as things are transitioning over. The sermorelin will be around, tesamorelin will be around, and there's a newish one called macimorelin, MACI morelin. Very similar effects. The macimorelin has some interesting research, particularly in fatty liver disease, which is where the liver becomes infiltrated with fat, usually due to diet and sedentary lifestyle, but can be due to genetics or genetic variants. And so patients will not be able to use their liver as efficiently because of the lack of this, or because of the presence of this. And the macimorelin has some interesting research there. It also has some interesting research in ICU patients with maintaining the diaphragm muscle integrity. So as patients go on a ventilator, their diaphragm becomes weaker, just like if you stop doing bicep curls, your bicep would become flaccid or weaker. And so the patients that were put on this growth hormone secretagogue were able to maintain the muscle density of their diaphragm, even in the face of ventilator use. So that was pretty interesting.
That's great. Okay, so that's the secretagogue. I mean, well, I guess you call those secretagogues, right?
Yes.
Okay, so now we'll move on to your next choice in the next category.
So it depends on the patient, and almost always if there's any sort of inflammatory state. So if we're talking about a very healthy patient who is trying to work on their aging processes. And we know that aging is related to cellular health in general, mitochondrial health, et cetera. And so if we can work on those things, we can improve the health of the cell. If we can decrease the inflammatory state of the body in general, and then work on the cellular health, we're golden. So one of the things that we do is addressing their intestinal health. And there's a couple of peptides I really like for this, and they're available orally, which is really nice. And I think that they will probably still be available after this FDA change. And so BPC 157, which people are familiar with, I think one of the pieces, this is a naturally occurring peptide that comes from the stomach that its original design, I presume from God, was to help to treat or prevent stomach ulcers from occurring. But the interesting research is in things like tendonitis, in joint arthropathy, in other pain syndromes, that it can be very helpful in healing wounds, etc. Most of that research is done in animals, but there is an interesting study done by Dr. Lee in intra-articular injections in the knee. And the benefits of that are something like 80% in patients who were treated with intra-articular knee injections in his lab. Again, just one human study, but very compelling evidence.
I think it's important for people to know too that oral BPC 157 is better targeted for the intestines, as you said, and that the injectable is better targeted at the area of the wound. So if you were injecting subcutaneously, inject right close to or into where, like he did with the knee, into the area of trauma. Is that what you would tell patients too?
Exactly. And I would tell my patients to do that. Of course, because the oral is available, one of the things I think that's a clinical pearl that I want people to remember is if your problem is in your stomach, you actually need to open the capsule and take the BPC by mouth with the capsule open, because if you're taking it with the capsule intact, it's going to bypass the stomach and won't even start to work until it gets to the small intestine. So there are lots of new delivery methods that are coming out, some nanoparticles and some other delivery methods that will be very effective. But keeping in mind right now, if you're treating a stomach or esophageal problem, there's some interesting literature around using it for dental issues. And so opening the capsule and pouring it into your mouth and swallowing it with the capsule open, unless you're treating something below the stomach, you really want to do that. It doesn't taste great, but hold your nose.
Yeah. I was just going to say that would be right before you said it, that because I just had some dental procedure, and my doctor in Beverly Hills said, take the BPC, open the capsule, and brush with it right on your gums, because that's going to help to heal that area that had the trauma, the surgery. So I haven't done it yet, but I've been, and now that you're telling me to take it even intestinally, take it out of the capsule, that's even really beneficial, because I've been just swallowing it, thinking it was going right to the stomach. But you're saying it'll go to the stomach, but not to the colon?
Yes.
So take it out and just hold your nose and take it. Okay, good.
And then if you want to treat small intestine and lower, you can use the capsule whole. But just realize if you're taking it by mouth, it's not going to get to your stomach or your esophagus when you take it that way. The other one I really love, I think is important, is the lorazepam, and that also is in phase 3 trials for for celiac disease. So very exciting, but we need to keep in mind its mechanism of action is repairing that tight junction, that space between the intestinal epithelial cells that protects the body from the invaders, both allergens and microbes. And so if we can maintain that tight junction with this peptide called AT1001, if we can maintain that tight junction, then we can get some really good benefit. The other things that break down tight junctions are infections. So anytime that you're having intestinal symptoms with an infection, for example, our most recent pandemic, a lot of my patients had intestinal symptoms with their viral infection. And so we will use this for them. The other thing that breaks down tight junctions is cortisol, or stress hormone. So in your patients that are particularly stressed, we want to put them, consider protecting their tight junctions and their overall health of their body, because almost all health begins in the gut. And if we can keep the inflammation there at a minimum, then we can decrease inflammation in your whole body.
And for those who don't understand what this mucosal lining, there's a name called leaky gut, which is a little more graphic, but it does explain what Suzanne just described to us. So that is a key element of your overall health, is to prevent leaky gut. Suzanne, they just signaled me that we only have a couple of minutes left, and I know I'm cutting us short, and this is frustrating for me because there's so much more I want our viewers to know. So I'm going to invite you back. We'll give it a few months to let people digest, no pun intended, talked about, but also we want to get your book out there and get that traction on the book and have some people read it and so forth. So I know you've offered a very generous gift to our viewers, so to help them on that journey. Could you just give us a quick explanation of what you'd like our viewers to do for just a nice incentive from you?
Sure. We're giving a free PDF of the first chapter of the book. It's if you just go to Vine, as in grapevine, vinemedical.com/counterclockwise. You'll get the first chapter of the book. And when the book comes out, we'll send you an email telling you that the book is now available on Amazon. And I believe it's Barnes and Noble and in airports.
I love that. And, believe me, everyone, when you read that first chapter, you're going to be frustrated that you can't go right to the rest of it. But that will come in time as soon as Suzanne's publishers are ready. So, okay, well, I just want to thank you so much. And I'm so happy that I'm sorry that we didn't get to meet at A4M, but I know you're going to be lecturing next year, right? In December?
Yes.
So what's your lecture, the title of your talk?
I'm lecturing this month on all roads of health lead to the start with the gut.
Oh, good.
And then the one in the fall will be on bioregulator peptides.
Okay, good. Well, you and I are both have that in common, which we didn't talk about today, but with Dr. Bill Lawrence and our involvement in his clinical trials. So that's a whole other subject. That's why we need to have you back. So I do want to say again, thank you very much for taking the time. I know how busy you are, and I am going to follow up with you on that new peptide that you just mentioned. I'd like to get some avenue to obtaining that.
Okay.
So very good.
Thank you so much, Michele. It's been a treat.
Okay, take care, Suzanne. Bye-bye.
Bye.